Perfect. So again, I'm Jeff Ryckman. I'm an associate professor at WVU Medicine, and today I'm going to talk about radiotherapy for people with metastatic non-small cell lung cancer. Now, I do want to kind of start this the way I start every single consult. It's not okay that you and your loved ones are dealing with this, and everything about this is a traumatic experience. And so I think the emotional component of care and trauma-informed care is so important. I wanted to put in a few slides on it, but I kind of just felt it was appropriate for me to really just stick to the topic of radiotherapy. But I feel like both of those things are fair to say. It's not okay you're dealing with this, and everything about this is traumatic, but we can focus on the bright spots together. So, some disclosures, none of which are relevant to this talk. But a bit of a shameless plug, but based on the prior presentation on ADCs, I'm working on an application to help radiation oncologists and treatment teams, which will be presented at the European Society of Therapeutic Radiotherapy and Oncology in Stockholm next year. It's an evergreen review to help determine whether medicines such as ADCs should be held during radiotherapy, depending on site treated and number of treatments based on things like mechanism of action or how medicines work, and biological half-life or how long they stay in the body. Although apps are helpful, in reality, these are multidisciplinary decisions made by your local oncology team. Chance favors a prepared mind, but in today's world, it may favor the mind that can find the relevant information most efficiently. So the resources above is and always will be free to use to help clinicians spend less time searching for technical details and more time with patients and their families outside of work. My biggest disclosure is that I'm a radiation oncologist and I'll do my best to temper my own biases. Also, full disclosure, again, as Eric had mentioned, unlike the other esteemed panelists, I am not a lung-specific oncologist. Instead, I'm a generalist who treats a variety of cancer and non-cancer conditions with radiotherapy. So, radiation therapy uses carefully targeted energy to damage cancer cells so that they can no longer grow. It is not like nuclear accidents or comic book radiation. It's a safe medical treatment delivered with precision. And so there's three different types of oncologists: the surgical oncologist, the medical oncologist, and the radiation oncologist. And radiation oncologists work closely with medical oncologists and surgeons as equal partners in your care. So radiation has really come a long way. We've only really known about it for a little over 125 years. Actually, it's coming up on 130 years next year. And so how has radiation evolved? Well, here what we're seeing is an X-ray, and we used to use these China markers or wax pencils. It was on every radiation oncologist's desk to design these fields. And we'd just be able to shoot from the front and the back, and sometimes we would gauge the dose based on skin reaction for deep-seated tumors because we could only do so much on paper, right? But I'm not trying to knock on historic techniques. They're still tried and true, and often we do simple plans are best, which we'll dive into. And we would actually like take calipers and like measure the thickness of tissue that we were treating to calculate how much radiation to give. So it's not like we had like 3D printers back in the day to do stuff like that, but I digress a little bit. So now, presently, this is a PET scan that shows a lung tumor and a spot in the bone on a PET CT. They kind of are bright in areas where the tumor is using energy. But it's also kind of excreted through the kidneys and the bladder. So that's just normal activity in the kidneys and the bladder. But that's a lung tumor and a spot in the bone. And now just think of cell phones over the past 10 years as well. Technology's come a long way. The same could be said for advancing medical technology and radiation. So we used to plan by hand, and now we use computers. So this is an example of historic lung radiotherapy. I think that says 72 right there. And so we just treat from the front and the back. And this is from Learning Radiology, a fantastic website. But really, this is what it was called, square pneumonitis. So what's pneumonitis? Pneumo means lung, and itis is inflammation of the lung. So in this case, the patient had cough, shortness of breath, sometimes low-grade fevers associated with this. But in time, this resolved. And this is what it was called, square pneumonitis. You know, we simply don't see this today. But in the long run, this settled down and the patient was able to breathe better. So there's short-term side effects and long-term side effects. And this is kind of a good example of a short-term side effect from radiation.